graduate of the University of Zimbabwe, School of Medicine, completing a MPhD degree in 2006. And she completed the MEd in Obs-Gyne in 2016. She also did a diploma in HIV management with the College of Medicine of South Africa. She's also she's certified in a minimally invasive gynecologist surgeon. She was certified by the European Academy of Gynecological Surgery. She worked as a research clinician at the UZCHS, the Collaborative Trials Network, doing microbicides research. And she's a reproductive endocrinologist after doing a 2-year fellowship in reproductive endocrinology in Cape Town. So Dr. Mbizai Majangara Karaga, it's a pleasure to introduce you. Over to you. So your topic is endometriosis associated infertility. Can we predict reproductive potential?
Afternoon, colleagues. Dr. Madzire, thank you for the kind introduction. So I will discuss endometriosis-associated infertility and can we predict reproductive potential. I am not able to move my slide. I don't know if there's a way to help me. Okay, so as a background, we know that 30 to 50% of women with endometriosis suffer from infertility, and 25 to 50% with infertility actually also have endometriosis. The monthly fecundity in those with endometriosis is low and has been reported to be about 2 to 10%, and is lower with increasing severity of disease. This is compared to a monthly fecundity of 15 to 20% for healthy women. So this meta-analysis did confirm what is known about how endometriosis affects fertility. We know it causes distorted pelvic anatomy with extensive adhesions. If the ovary is encased in adhesions, then it cannot release the oocytes, and then association with abnormal follicular development and the various toxins that were mentioned by earlier presenters, resulting in lower oocyte yield with assisted reproduction and abnormal embryo development. And then tubes encased in adhesions are associated with hydrosalpinx. They cannot pick up the oocyte. Also association with altered peritoneal function and endometrial receptivity related to inflammatory markers, progesterone resistance, and altered endometrial gene expression, all resulting in abnormal implantation. So even when the women do fall pregnant, there's an association with several complications, such as ectopic pregnancy from the adhesions, abnormal implantation resulting in miscarriages, antepartum hemorrhage, preterm birth, intrauterine growth restriction, preeclampsia, and some authors are talking about Becker's hypothesis that the altered intrauterine environment may actually affect offspring in the future. This requires further studies. So the question, we know that strategies for therapy for women with infertility with endometriosis, so there's talk of expectant management, medical therapy, there's no role, but I will discuss this later on. And then in terms of surgery, ovarian stimulation or intrauterine insemination, as well as assisted reproduction. But the question is there an objective way to decide which routes to take for the individual woman who has endometriosis? So can we predict pregnancy rates with the non-IVF strategies, that is expectant management or ovarian stimulation, and especially after surgical management? So there is the endometriosis fertility index that I will discuss today, which is a validated clinical tool, the only objective tool at the moment that can predict fertility in women who have been managed surgically for endometriosis. It can predict the non-IVF treatment pregnancy rates, that is expectant, or ovarian stimulation with IUI. and the condition should be functional uterus and gametes. So this endometriosis fertility index was proposed by Adamson and Pastor in 2010, published in Fertility and Sterility. So what they did a prospective follow-up of women that they had managed in their center who had endometriosis, 579 of them, and they collected data on historical factors and surgical factors, that is laparoscopy, hysteroscopy, and then they did a comprehensive statistical analysis to see which factors were predictive of fertility. And then they came up with the endometriosis fertility index, and they tested it on an additional over 200 patients, and the results validated their earlier findings. So they proposed it as a good internally validated clinical tool that could be used to reassure women with a high endometriosis fertility index that they could try 9 IVF strategies for achieving conception. And also those with low endometriosis fertility index could immediately be referred for IVF. So this image is showing the endometriosis fertility index. So it has historical factors and surgical factors. In terms of the historical factors, we are looking at the woman's age. If you look at the bottom here, it's looking at the woman's age, the duration of infertility, and if she's had a previous pregnancy or not. And we will find that the historical factors contribute 5 out of 10. So the total score is 10, and historical factors are very important. They contribute 5 out of 10 of the points. Then there are surgical factors. In the surgical factors, there is a least function score. So this is a qualitative assessment of the state of the pelvis, that is the ovary, the fimbria, and the fallopian tube after surgery for endometriosis. And so this is done on each side separately, on the left side, on the right side, with a score of 0 being if any of those 3 is absent on that side, or if it's totally non-functional, and 1 being severe dysfunction, until we get to 4 where we have normal function. So the least score, one of those 3, which is the least score, is what we put on the table, and then we add the figures for both the left and the right side to get the total least functional score. And then the revised ASRM classification is also then looked at. So we know that according to that classification, an endometriosis lesion, if we have an endometrioma, or if there's obliteration of the pouch of Douglas, that is a score of at least 16. So if any of those is present already, it then gives us those values to input onto the table. And then the total AFS score only contributes 1 point to the whole endometriosis fertility index. So it does show us that the revised SRM score is not, on its own, is not effective in terms of predicting pregnancy. So after computing all these figures, we come up with the total AFI score, which includes historical, surgical, and factors. This EFI score is then put on that. If you look at that graph, the EFI score provides us with a graphical presentation that tells us the probability of a woman achieving a pregnancy with non-ART strategies over a 3-year period. If we look at that graph, we will see that majority of the pregnancies occur within the first 6 months post-surgery here. And then they start to flatten off after 12 months. And the higher the EFI score, the higher the chance of pregnancy. So several teams have took this up and started performing the endometriosis fertility index scoring. So this is a systematic review published in the BJOG in 2020, which included 17 studies from 8 different countries, different centers, and they validated the endometriosis fertility index. And they found that the cumulative non-ART pregnancy rate at 36 months was with an EFI score, which is high of 9 to 10, was 69%, and going down to as low as 10% with an AFI score of 10%. And they found significant differences in pregnancy rates between all the categories. So in terms of clinical decision-making based on the EFI score, it's recommended that if the score is 6 to 10, so 6 and above, then the woman may have expectant management or ovarian stimulation IU with intrauterine insemination. Obviously, if you're going to do expectant, this is a young woman with no other infertility factors. And if the score is 0 to 5, then assisted reproduction is recommended. Strongly advised if it's 0 to 3, and those with 4 to 5 who have other considerations, maybe not so much a pregnancy desire at the moment or with socioeconomic issues, may attempt non-ART pregnancies. If we're going to do non-ART pregnancies, it's important to reassess every 3 to 6 months and decide based on several factors: sexual, quality of life dysfunctions, age, financial, etc. So the World Endometriosis Society consensus on the classification of endometriosis, published in 2017, gave a strong recommendation that the EFI is a simple, robust, and validated clinical tool that predicts fertility outcome for women following surgical staging of endometriosis, and may have considerable utility in developing treatment plans for infertile women with endometriosis. All women with endometriosis undergoing surgery should have a revised ASRM score and stage completed, and those with deep endometriosis should also have an ENDOMETRIOSIS classification done. Those with future fertility desire should have an EFI score done. So what are the limitations? As I've stated earlier, it is not useful if there are additional infertility factors, and also it does not account for the degree or extent of surgery, e.g. those with deep endometriosis. So is there utility of the EFI prior to surgery? In other words, should every woman who desires fertility have to get surgery to get an EFI score before deciding on fertility route? So I will discuss 2 studies in specialist endometriosis from specialist endometriosis centers that have tried to look at this. So this is one study from British Columbia. They have a cohort of, so at that time of publication, there are 2,453 women in their endometriosis pelvic pain interdisciplinary cohort. And they selected women who were less than 40, who had complete data collection, that is data regarding historical factors, transvaginal ultrasound findings, and laparoscopy with complete revised SRM and EFI staging, and they found 86 women. So of these 86 women, they compared those who had a positive sliding sign versus those who had a negative sliding sign. This is the one that Dr. Mbere mentioned in the morning, obtained on transvaginal ultrasound. And their outcome measure was the prediction of the ability of this sliding sign to predict a low EFI score of less than 6. So their conclusion was that a negative sliding sign, endometrioma, and an EFI historic factors predicted an EFI score of less than or equal to 6 with a high degree of accuracy, with a sensitivity of 87.9% and specificity of 81%. Another group led by Thomas Setti from Belgium, they also did a prospective observational study in 82 patients undergoing complete laparoscopic endometriosis excision. And they classified them into 3 groups. So there was one, so for each woman, they assessed EFI type A, which was based on non-surgical clinical and ultrasound findings only. And then they would also calculate an EFI type B, which is combination of non-surgical clinical or ultrasound findings plus diagnostic laparoscopy, as well as a final EFI, which was post-surgery. And here their outcome measure was the clinical and numerical agreement of EFI types A and B with a final EFI score. And so agreement was defined as clinical EFI scores, as clinical if the EFI scores were within the same range. So if 0 to 4, or 5 to 6, or 7 to 10, and numerical if there was a difference of 1 or less. So they found that there was a high agreement rate between estimated EFI type A and B with the final EFI score in their study. And essentially an EFI type A, which was only based on clinical and ultrasound finding, had identified the correct EFI at least 83% of the time, and increased by about 10% after a diagnostic laparoscopy. So in conclusion, evidence suggests possibility to translate an end of surgery score into a potential pre-surgical triage system. So the limitations of EFI scoring prior to surgery are obviously that it requires availability of high quality expertise in gynecologic ultrasound with high volumes, which may not necessarily be available everywhere. And it still requires validation studies, one, to assess in terms of prediction of low EFI score, as well as regarding fertility outcome. As you see, the 2 studies I mentioned were only just assessing the prediction of low EFI score, not necessarily the fertility outcome. So on the other hand, it is essential to preserve fertility in patients with endometriosis. And what are the strategies? Early childbearing before there's additional impact of age on a reduction in ovarian reserve, and then maximize medical therapy to avoid repeated surgeries, and then also careful selection of surgical candidates. As has been mentioned earlier, endometrioma surgery was shown to reduce AMH by 38% and even higher if there was bilateral cystectomy. And then also, should we consider assisted reproduction prior to surgery? So in a woman without an obvious indication for surgery, with a low EFI score, then it may actually be good to do ART prior to surgery. This is and reserve surgery for women with a hydrosalpinx or too large an endometrioma that will interfere with oocyte retrieval or suspicion of malignancy or other. And we know excision of endometrioma has not been shown to improve IVF or ICSI outcomes. And then should you go in to do surgery for endometriosis, then especially the endometrioma, careful intraoperative techniques with avoiding multiple incisions and considering either unilateral cystectomy and ablation on the other side, etc. Avoid repeated surgery, and then consider oocyte or embryo cryopreservation prior to surgery in women who require surgery. There's also now the discussion around should all women with endometriosis undergo routine oocyte or embryo cryopreservation. So at the moment, that is still a bit premature because there's currently no evidence of an absolute increase in live birth compared to a woman who does not do this and then eventually has IVF and embryo transfer in future. So the take-home message is all women with endometriosis undergoing surgery who desire future fertility should have a revised ASRM stage plus EFI score completed. This is good clinical practice and it will provide an objective measurement, something that you can also use for counseling your patient and to assess outcomes. The place of EFI prior to surgery remains to be established, and overall we need to preserve fertility in women with endometriosis. That's the end of my presentation.
Thank you very much, Rumbi, for the stimulating talk. Now we entertain some questions. Please, you can just unmute yourself and raise your question, or you can post it in the chat, or raise your hand. While wait for any question,
hello,
Dr. Mweg.
Can I
please go ahead.
Hello.
Yes, Dr. Vama, go ahead, please.
Okay, no, sorry. Thank you very much, Dr. for the wonderful presentation on this EFI. Just one comment that unfortunately we couldn't hear the hashtag classification. Maybe it should have been maybe a better, instead of the revised ASRIM, because I think there's a study where they found that in 80% of experts, they could not agree on the RIASM classification. Can you just comment on that? Because I think the NZN classification actually tells you exactly the degree of involvement of the structures that are important in fertility.
Okay.
Thank you.
Okay, so the revised ASRM classification does have a lot of shortfalls, like you have mentioned, and it essentially does not correlate to pain. It does not tell us if anybody has deep endometriosis or extrapelvic endometriosis, and it essentially does not predict fertility. So those are the issues, and like you've mentioned, there's a lot of inter-observer variability, but it's something that it was the original classification that has been enshrined for a long time, and I'm sure experts do find it difficult to let go of it. And then in the EFI score, as I showed you on the other slide, that out of 10 points, it only contributes, the total revised ASRM score only contributes 1 point. So that is just showing us that in terms of fertility, it essentially will not guide us. I don't know if I've answered your question. I hope I've answered it.
No, thank you, yes. Yeah, thank you.
Do we have another question? Anyone else with a question? Dr. Majangara, I think your talk has been well understood. Thank you very much for preparing this talk for us. I think I'll ask the next presenter to start sharing his screen. Then I will introduce